and we're going to be working on Phaco Basics today. So we're going to talk about the basics of phacoemulsification. How do you start, and some concepts that will help you as you begin to learn surgery. We're going to watch a full of surgery, and we'll talk through the points, and we'll break those steps down into individual steps. So when you're doing phaco, you're going to need to have two incisions. The first one's a paracentesis. After you make that paracentesis, you'll inject medicines into the anterior chamber. As seen here, this is sugar cane. It's a mixture of epinephrine and lidocaine to help increase pupillary dilation, increase comfort. And then we'll inject viscoelastic. This is a dispersive viscoelastic, viscoat, that will help to expand the anterior chamber, maintain volume, prevent collapse, and protect endothelial cells. The main wound is we're operating temporally in this case. The incision can be made either temporally or superior depending on surgeon preference. It's important that your tunnel have an adequate length. If it is too short, it'll create problems of wound leak. If it's too long, access will be an issue. The capsular rhexis is made with the cystotome needle to start. Initial scratch, I like to start fairly centrally and then work out all the way out to the desired diameter of my rhexis. So I've got that curve started here. Then I'll use a Utrata forceps to pick up that flap, and we'll bring it around for a curvilinear capsular rhexis. Grasping close to the tear is advisable. It gives you the most control. You can re-grasp as needed, but I'm always grabbing right on the edge of that. I try not to distort the wound as I move that Utrata through. I use it as a fulcrum, so I'm not depressing it. I'm not pushing down. If you push down on that wound, you'll lose a lot of viscoelastic. Ideally, we're going to create a nice round, somewhere around 5.5 millimeter rhexis. That'll give good stability for our IOL. It's really safe as we're operating. If it's too small, you'll have difficulties removing the pieces. You can vary the size of the rhexis depending on the density of the nucleus. The hydrodissection, this is performed with an Akahoshi cannula. In this video, that Akahoshi cannula right underneath the rhexis edge, injection, see the fluid wave, come around, decompress, that completes the wave, and now that nucleus should spin freely. I really like to see that nucleus spinning at least 90 to 180 degrees. The phacoemulsification probe is brought in. We're going to make a central groove. This is a stop and chop technique, so that means we're going to make a central groove. We're going to break the nucleus into halves, and then we'll chop those halves. Very important that you modulate the phaco energy for this the given case, meaning that as a needle is going forward here, if it's pushing the nucleus at all, I want to increase my phaco energy, because the goal here is not to use the needle like a shovel. I'm actually just presenting the tip of the needle to the nucleus and letting the ultrasound energy do the work to emulsify that nucleus. Bring in a second instrument. In this case, looks like it's a quick chopper, and we're going to use that to get both instruments down deep into the groove. That groove down at the base. There you go, and it actually looks like that's a Nagahara, my mistake. That once the two segments are cracked, then we can start to chop these into pieces. I like to chop this nucleus into 3 or 4 pieces per hemi to make them smaller, and you're going to get more efficient phacoemulsification of the segments. I prefer when we're starting out learning to do phaco, this video is demonstrating the preferred technique that I have for beginning chop techniques. Is that we're going to chop these pieces up, and we're actually leaving them in place. You could remove them, and switch to a different setting and do the quadrant removal and remove the pieces as you chop them. There's a certain amount of stability and control of the heminuclei and the quadrants as you leave them in place. So here you're going to see me, I'm chopping them and leaving them in place. Really important, the position of the phaco needle here needs to be down into the endonucleus and not too far anterior in the softer epinucleus. As the instruments are placed, you'll see here that chopper is going to go underneath here to chop this segment in half. When I brought it forward with the phacoemulsification probe, brought it up in the anterior chamber, and then I chopped it again in place, now removing the individual pieces that are left behind. This setting at this point is now on quadrant removal. Previously, when we were chopping, it was on the chop setting. Now this is on quadrant removal. You can go back and forth on this setting. Here you can go to chop, to pick that segment and bring it forward. I'm using that chopper now to further subdivide those pieces, make this very easy and smooth removal. That second instrument should be in position to help you. That second instrument will help to feed the pieces to the tip. You can also use it to help to keep the capsule back in case of surge. Newer generation phaco machines, that surge is very infrequent, so we tend to help you have that second instrument closer to the tip to help me with phacoemulsification rather than simply trying to distend the bag posteriorly. On the quadrant removal setting, you want to kind of titrate how quickly you get down all the way in the bottom of position 3 based off of the density of your nuclei. For some softer nuclei, you may not need to spend much time all the way down in position 3 as things will aspirate. This is a slightly more dense nucleus, and so that requires more phaco energy. Every time I want to grab a piece, I'm rotating it so that it's an easy grab with my phaco needle. I don't have to take that phaco needle far out into the periphery or close to the posterior capsule. I'm presenting that needle close to the phaco fragments here and aspirating them. That'll come to the tip, and then I can bring it to an area of safety here in the central anterior chamber. This is a very safe position to perform phaco. I prefer in the iris plane, a little bit more anterior. I do not prefer to phaco in the bag. That's probably old habits from older generation phacos, machines where a surge was more common and you wanted to avoid nicking the bag with the needle. You see, we'll look around, make sure there's no other pieces. If we don't see any pieces, we're going to remove that second instrument. We'll take that phaco tip out of the eye. Now we're coming back with the I and A handpiece. This is a coaxial I and A handpiece, so it has both irrigation and aspiration. You can separate these out and have separate bimanual I and A techniques with an irrigation port and an aspiration port. In general, I prefer to remove the subincisional cortex early, not wait for the last bit there. I like to remove that quickly. Use that the tip of that I and A handpiece to go and grab cortex, get to occlusion, and then hit that gas pedal to remove it. You can spend a moment polishing the anterior capsule, removing some of those lens epithelial cells. Perhaps that may prevent early PCO formation. At this point, we're now ready to refill the capsular bag with viscoelastic agent, and we're going to inject our intraocular lens. Important to fill that bag completely. You want that IOP to be physiologic at this point. If the eye is too soft, it will make injection of the lens implant more difficult. Use a second instrument to stabilize and bring that injector into the wound. And we'll have nice controlled injection of that lens implant into the capsular bag. At this point, you could use a second instrument or the I and A handpiece in order to help position the IOL more completely. Here we're using an I and A handpiece. We're just going to tuck that in, make sure that we're well within the bag. At this point, we're now ready to remove the viscoelastic. This is a moment where you want to spend some extra time making sure that all the viscoelastic agent has been fully removed. If not, you'll see IOP elevations in the day after surgery, so we'd like to avoid that. So we're going to talk about the paracentesis creation, viscoelastic injection, main wound construction, the rhexis, hydrodissection, nuclear disassembly, cortical cleanup, IOL insertion, and wound closure. So the side port, or the paracentesis, this incision is really important to you. There's a couple of considerations to make. It's not exactly where you want to make this. Anywhere from about where your planned main wound is, in a range from about 45 degrees away to your left for the right-handed surgeon, up to 90 degrees, depending on surgeon preference. I prefer mine to be about 60 degrees away. The important features here, we're using a second instrument in the right hand to provide a backstop. And this, as you're applying pressure, your paracentesis blade will go through that cornea. If you don't have a second instrument for a backstop, you'll tend to roll the eye more, distort it, you'll lose sight of the central cornea. The consideration here, you want that paracentesis to be relatively flat. You don't want to approach the eye with the tip of that instrument pointed directly at the capsule. That's dangerous. If you slide through quickly, if you're directed posteriorly towards the capsule, if you slide through suddenly, you will hit the capsule and you'll break that anterior capsule more quickly than you'd like to. In order to prevent that, stay parallel to the iris. Some gentle pressure there. We want that incision to be 1 to 1.5 millimeters long so that it will self-seal properly. In order to get medication into the anterior chamber, we're going to use a cannula. We need to get into that. Here you're going to see there's a little bit of struggle at first, and then a redirection and more easily injection into the anterior chamber. A few quick tips. As you approach that paracentesis with your cannula, you want to think about running that cannula on the floor of the incision rather than the roof of the incision. Right here you'll notice some difficulty getting that's because the cannula is hitting the roof of the incision, and so now that's redirected a little bit more posteriorly to slide along the floor of that tunnel and will go into the anterior chamber easily. As you're injecting viscoelastic here, make sure that the eye is not collapsing on you. So you want to be injecting as you enter the eye so that the volume of the anterior chamber is being maintained. And the amount of viscoelastic, once you start to see the lens iris complex being distended posteriorly away from you, you probably have enough viscoelastic in the anterior chamber. You do not need to overfill this, to an IOP of 80. Right here you see things moving posteriorly, and that's it. That's all we need. A little tap to verify physiologic pressure. When you want to construct your main wound, considerations need to be made for placement. For the right-handed surgeon, this is going to be right about 180 degrees, perhaps slightly to the right of that to facilitate manipulations during surgery. This wound tunnel needs to be the appropriate length. About 2 millimeters is sufficient, something either a slightly square or just short of a square in terms of its shape. That approach will your initial approach with the keratome knife needs to be initially vertically to get into the corneal stroma. If you are too flat on the eye, you'll just make a very superficial initial portion of your wound, and that very superficial anterior portion can rip or tear. So you'd like to approach the eye with initially a slightly vertical approach. Right here you see entry and about 200 microns in. Now I'm flattening out and tunneling up through the clear cornea here. And then that tip, once I reach my desired length, I'm just going to take a moment to make sure that I enter, waggle that tip so that it enters it. I'll see the tip of the blade enter into the anterior chamber, and then I'll flatten back out. So it's sort of a, here, heel up to enter initially, then a heel down to tunnel forward. When I get to my extent, I'll do a heel up again, which will point the toe more centrally, and then I'll flatten out again to enter to create a nice, smooth entry. Again, care should be used here. Use that second instrument to give yourself some counter pressure so that you can enter into the eye. Rhexis. I start fairly central. I like to move from central out to the left, and I'll turn that flap over. Think of that needle tip as a hook almost. That'll help you turn that flap over. And when grasping, it's really important to grasp right at the edge of the flap. And you can manipulate this when you let go here, so you have that edge to be grabbed. I want to make sure that the size of the rhexis matches the nucleus. You can, for phaco, it's going to be a 5.5 millimeters is the goal. This is a skill that early on you'll need a lot of practice to master creation of a capsular rhexis. Hydrodissection is for me one of the more important steps because you want this lens to spin. So you see that fluid wave and that lens rise a little bit. Now I'm coming and I'm decompressing 180 degrees away. You see the completion of the fluid wave and a nice spin. I need to see that spin before I proceed with the rest of my phaco, because if it's not spinning, that could mean that the hydrodissection was done properly. There may still be adhesions there. Sometimes that means there's other problems, like maybe there's zonular laxity. But in general, should be able to get one good fluid wave, a decompression, and then a rotation of that nucleus should be sufficient to facilitate a nice, easy surgery. We're going to walk through a modified divide and conquer procedure. This is where I like to start residents out with. And so you're going to make this central groove. When you're grooving, you don't want to see the nucleus move. The goal here is you are presenting the phaco needle to nucleus and allowing the ultrasound to do the work. It is not a shovel. We're not grooving by digging out with the phaco tip. You're bringing that nucleus into contact with the phaco and it's emulsifying it. Get down deep into that groove with both of your instruments. You need to make sure that you've grooved appropriately, of an appropriate depth, and that depth needs to be through the endonucleus. That's going to allow you to crack this with minimal difficulty. Again, down deep into that base and separate those pieces. And here you can take that and use that second instrument to subdivide those nuclear fragments. It makes your job easier. If you take a whole quadrant and try to phaco that in one bite, it's going to be very inefficient for you. So this, this maneuver here to grab is going to be helpful. This, chopping here, again, subdividing that larger piece, is going to facilitate efficient phacoemulsification of the nuclear fragments. You'll see I don't reach in deep into the bag. I'm coming right to the edge of that nuclear fragment and letting the aspiration do the work to bring the piece to me. Same thing here. Watch how steady the phaco tip is there. It's a backstop when you're chopping. It serves to block the movement of your second instrument to allow the crack to occur. You do not want to push the phaco tip deeper into the bag when you're chopping. Here the second instrument is subdividing that piece for me. Everything's just right in front of me. The phaco machine, the aspiration works wonderfully well. It brings that piece to me so I don't have to go chase after anything down deep into the bag. Removing some epinucleus that's present, and there we go. This is a stop and chop technique, so very similar. This is the way I like beginners to learn how to do divide and conquer to start with, and then the next step after divide and conquer is the stop and chop. We make that central groove, again, down deep through the endonucleus, those instruments down into the base of that groove. Now we're going to spin that nucleus and put that underneath the rhexis edge, and I'm engaging with the phaco needle, but you see how that phaco needle is really quite stationary. It's there to serve to immobilize the nuclear hemisphere there so that I can chop it. So again, I'm not bringing the tips together. Now, I mean, the tips are coming together, but all the movement's happening with my left hand with that second instrument. My right hand is quite stable. You see that thing, the tip staying right in the middle of the chamber. It's not, the phaco needle is not traveling down into the bag at this point. I'm bringing the pieces up. I'll use that quick chopper in order to subdivide those pieces. So they've already been broken into 4 pieces for each heminucleus. Now I'm further dividing them into eighths, and it makes a very efficient phacoemulsification, as now I'm grabbing the pieces, subdividing it with the chopper, and those pieces will disappear quite quickly into the phacoemulsification tip. See that hydrodissection has facilitated really smooth rotation of the nuclear pieces. And use that second instrument. You'll see that every time. It's just really gentle motion there. No stress on the zonules. It's a sweeping, arcing motion with that second instrument in order to rotate things. And I was rotating things so the piece is right in front of my tip. So I don't have to search for it. I'm not at awkward angles where I might accidentally, nick the iris or the rhexis edge with my phaco needle. Everything's just right in front of me, and that's facilitated with good rotation. As you get down closer to the last pieces, you do want to be mindful that your positioning of where you put your phaco here is really important, because you don't want to aspirate the capsular bag. So I make sure that I'm putting my phaco piece right up next to the piece before I engage aspiration. You don't want to give opportunity for any stray iris or capsular bag to enter. So I just position that handpiece right in front of the piece I want, and then step down into position 2 on the phaco foot pedal. Cortical cleanup should be a very quick maneuver, particularly if you've done nice hydrodissection, should be free. I prefer to clean up the cortex that's underneath, or the subincisional cortex first. Now, this is done by grabbing cortex, bringing things to the center, and then hitting that phacoemulsification foot pedal down to position 3. Here you see I'm polishing up some remnants. The IOL implantation, second instrument to stabilize the eye, I think is an important step. You can do it without it, but this makes things more comfortable for me. That IOL injection should be smooth. If you notice there's any damage to the haptics, you can abort. As long as everything looks good, we're putting that lens back into the bag. If you have a toric lens, you may take a moment to use a second instrument to position things, but a standard monofocal lens, we can complete the insertion here into the bag with the INA handpiece. And the viscoelastic cleanup, as mentioned earlier, important part to surgery. Early on, learners should spend extra time in viscoelastic cleanup. It takes a bit of time before you can actually see the viscoelastic that remains in the eye, but it's really important to remove that. If you leave viscoelastic in the eye, you will have IOP spikes after the procedure. We're going to talk briefly about toric IOL, a bit more advanced. This is something where you should have marked 180-degree axis out in the patient in holding, and now we're going to use that the ring and the marker, and we're going to confirm our toric alignment. After successful surgery, we're inputting this lens, and toric lenses have marks on them that indicate the axis of astigmatism. You can see those 3 dots. And so we're going to, this one needs a bit more rotation, and so it's going to rotate it full 90 degrees in order to get those marks just shy of my cornea toric marks. I like to leave them 15 to 20 degrees short of the marks for the viscoelastic cleanup. Give a little gentle pressure posteriorly on that IOL to try to hold it in place. You can see that viscoelastic coming out of the eye. Sometimes aggressive viscoelastic removal here could cause the lens to spin and come out of alignment. Fortunately, we've got a fairly stable position here. Now, removing the viscoelastic. Once I've got all the viscoelastic out, I'm confident that there's not much viscoelastic remaining. Then I'm going to use that handpiece to just gently nudge that IOL into position. I don't want to put stress on the zonules here, so I'm just making gentle contact, just enough to put us in alignment. Another more advanced technique would be for smaller pupil. This is a patient with Flomax use. And, the pupillary dilation here is not terrible, but we can make it better. The Malyugin ring is a great device surgically that can help keep that pupil appropriate size during the procedure. So that leading ring is placed underneath the iris. Then this is a Malyugin ring manipulator. But I prefer to engage that subincisional ring next. I think that eyelet is the easiest to place at this moment. Then we'll come over and grab the next two. Care here to make sure that the second instrument is not contacting endothelium as you move around in the anterior chamber. And grabbing that ring and placing it underneath the iris edge. Now our pupil will be adequately expanded during the remainder of surgery. At the end of surgery, we'll have to remove it. It can be removed using that same instrument to disengage the rings, and the inserter will actually remove the device. All right, well, I hope this has been helpful. Practice, practice, practice. Use every modality of simulation that you can come across. That will help you as you begin surgery on live humans, whether that be the IC virtual reality simulation or in a wet lab context with your surgical mentors. Spend as much time in practice as you are able. It will greatly assist you as you get started. Thank you so much for your attention.